Good afternoon, dear colleagues. We just start immediately with a live case from China, from Hangzhou. And I would like to ask the colleagues over there to start. Please go ahead, and very welcome from Frankfurt.
Okay. Play. Okay, please play the video. Okay, dear moderates, panelists, facilitators, dear friends and colleagues. So good afternoon. Welcome you all to the live demo session at CSI Frankfurt 2026. So this case is being transmitted from the second affiliated hospital, Zhejiang University School of Medicine, Hangzhou. So my name is Wang Jian'an. So let me it's my great honor to introduce you, my colleagues with me today. So next to me is the handsome guy, is Dr. Liu, Professor Liu.
Good afternoon.
Next to him is Dr. Ren, is a senior fellow. And also behind us, there are two technicians from the company. Also, we have a Dr. Lin, who is operating the transit subject echocardiography. And also we have a nurse over there. So now we invite Dr. Liu to introduce the case. Dr. Liu, please.
Okay, thank you, Professor Wang. Yeah, good afternoon, everyone. Okay, the patient is a 65 years old lady, and the patient has the history of rheumatic heart disease, and the patient received the mitral valve and the aortic valve replacement over 27 years. And the patient right now have the recurrent edema for over 5 years, even after the GDMT, including the diuretics, SGLT2 inhibitor. So still the patient has the symptom. So next one, please. And this is the echo. So the patient is the sinus rhythm. And still we can see right here from the TTE, the right atrium is enlarged. And the massive 4+ TR with dilated right atrium. Next one, please. And this is the TEE, or back. 往上一张. Yeah, we can, from the transgastric view right here, we can see the regurgitation is quite severe from the septal, anterior septal to posterior septal. And the regurgitation is massive, and the 4+. Yeah, so the strategy for this patient, next one, please. So we'd like to use 1 or 2 Dragonfly T system devices from the atrial to septal. And if possible, or if necessary, we'd like to use 1 more from the posterior to from posterior one. Okay, next one. Yeah, today we will use the device of the Dragonfly T system. Yeah, I think the design is quite similar with the Dragonfly M. Just 1 more knob right here to adjust the septal hub. Yeah, that's all for the case presentation. Professor Wang.
So actually, just now, Dr. Liu already mentioned this tricuspid system is similar to mitral valve system. However, we add 1 more handle to the big sheath. This is very good for eliminating the hogging, just tightly controlling the septal and the lateral. So now we can see, because we are concerned about we have only 30 minutes for demonstration, so we already nearly finished the procedure. So we can go back step by step. So could you go back to the?
So any comment for the?
Welcome your comments. What is? I would like to know what are your strategy for this kind of a case? How many dragonfly clips would be your suggestion for this type of case? Can you hear us? We cannot hear you. Okay.
So maybe we can ask the panel. I think it's quite a typical patient for that type of indication, but maybe we have some comments from the panel. Please. Feel free.
So initially, we are going to. Okay, keep on going, please.
So the main question that popped into my mind after seeing your strategy, so you're going for a clover technique, is why you decided on clover instead of bicuspitalization, which would be a technique that I might favor.
Yeah. So maybe I can try to answer this question. So because the regurgitation from the anterior septal to posterior septal. Yeah, so so we have to, I think we should the annular decrease of the diameter. Yeah, so clover maybe, I think it's a good way to do this. So this is the one option. So another option, we can still use 2 dragonfly system from the anterior septal, then still can correction or decrease the size of the annulus. So the 2 strategies. Professor Wang, you can have more comments?
Yes, can we see that the largely jet is coming from the anterior and the septal? So not much from the posterior and the lateral. Can you see that? So our strategy is initially is to put 2 dragonflies clips to try to eliminate the jet from the septal and the anterior. So after that, then we make a judgment whether the residue is large or not. If the residue is limited, we may add 1 more, or we don't even one more. We don't even need 1 more clip.
So did I get it right that you already put 2 clips into the valve? Is it right?
Yes, we already.
Okay, can you recall that we can just follow the procedure?
Yes, 1 by 1 from echo. Can you see that? This is the first clip. Can you see? So we are. Next one, please. So we are moving the clip toward the tricuspid leaflet. Next one, please. Can you see that? On the left panel is the left side is transgastric view. Now from the right side, we can still see the clip is above the leaflet, not diving. So what do you think this position is? Do you have any suggestions when this is our first clip? We already opened the flick. We get the device very close to the leaflet, but still above the leaflet. It's still in the red atrium. So what about your comments on the orientation or the position? Do you have any suggestions? How do we adjust the clip position? What do you think the orientation?
I think that's a great orientation. I mean, the gaps still look fairly prohibitive, though. I don't know if you would want to go more aortic and along the commissures.
So what do you? Oh, yes, thank you for your comment. Actually, because this is the first clip. We need to work more. We need to move it further to the commissure. Otherwise, we don't have a bigger space enough for the second clip. So now we move to the commissure. So,
yeah, I would agree. I think your starting point's good. I think the orientation is nice. You probably do need to come a bit more towards the commissure. I was just going to ask, in terms of prepping for these patients, and the comment was made about the coaptation gap, do you diarise them more aggressively to help optimize on the day your technical approach with respect to that coaptation gap? But I think you've got a good position. I'm just wondering what strategies you might have taken prior to them coming on the table to optimize.
Yeah, the coaptation gap, so about the 7 millimeter. Yeah.
Could you show the cohabitation gap?
Yeah, please.
Cohabitation gap.
你前面可以秀一下新平。
这个要 go over 这个
Yeah.
echo，要 go over。
So do you ask do you diarise your patients? Do you give them more aggressive diuretics
Yes.
to help reduce?
Yes, absolutely. We treat the patient with GTMD at least 1 month. The patient has, I think the patient is on several diuretics,
two.
2 diuretics.
Yeah, optimal diuretics use. Yeah, still the patient has the edema.
At least
Yeah.
put the patient on the GDMT for at least for 1 month.
Because often you can find if you if you really dry them out, particularly the ones with a large coaptation gap, you can help yourself on the day. It may not reflect their real life hydration status, but just aggressively drying them out pre-procedure can be quite useful.
I think in
Yes, I fully agree
during
with
the procedure, it might be helpful sometimes to upright the patient a little bit and to give a bolus of nitro when you try to grab.
And I totally agree, but I think it's totally different regarding the pre-diagnostics, because in the right-head cath, in the pre-diagnostics, the pressure of the right atrium, if I looked at correct, was only 3 or 4 millimeter mercury, and now it is 15, is it correct? The yellow line, 15 millimeter mercury for the right atrial pressure, so it is a complete other situation like we had in the screening right-head.
So this pressure is correct, I think.
Yes.
16.
16 over 10.
It's a bit high.
So it's much higher than in the pre-screening.
Maybe you give a 0 again.
Okay. 这个可以
check 一下 zero.
调零调一下，可以的。
Zero check.
Yes.
I don't think the patient
可以
has
调零
tricuspid stenosis. I don't think so. Okay. 你们调一调。
调零。
So you are just about to show us how you put the first clip in. Can we see the result after the implantation?
Yes, could you going down further? So now we, actually, I think we already diving into the.
Yes.
Now we are diving into the right ventricle.
Yes.
Now, so next one, please. We don't have full ID. Actually, the first ID is until now has not available. Isn't available in China, so it's a challenge for us. But we just try to make from the TE imaging to make a judgment whether the leaflets are on or not. So can you see that? Now this is the first clip. It's already there. However, it's already we already diving in the right ventricle. So can you make a judgment whether from the right side view, can you see that can you make a judgment whether the leaflet is on the arm or not?
Do you use the mid-esophageal view for 3D MPR to see if the leaflets are graspable?
Yes, we quite often to move the transducer from the gastric to the middle esophageal a couple of times.
The image quality for this patient is poor.
I think the transgastric view helps you optimize position, but for grasping them, if you don't have ice, I think the mid-esophageal MPRs are very useful.
Yes,
and then you don't have to move the probe into and out of the stomach.
But we still use quite a lot the transgastric view. Actually, we believe in transgastric view a lot. Occasionally, we move back to the middle esophageal to further confirm. So because the patient already, 20 years ago, the patient had 2 valve replacements, 2 metal valve replacements. So it's interfering the quality of transesophageal imaging.
The deep esophageal view kind of gets rid of the shadowing and patients with TAV or MAC.
Yes. So now we can see that the first clip, we already get the grip down, and now we already tighten the arm, 2 arms. So can you see that? We can see the next sign. So after the first clip was released, the regurgitation already was dramatically reduced.
And do you have also a view mid-esophageal with color, because the anteroceptor commissure we cannot see in the transgastric view.
Okay, thank you.你把这个看到食管中段的超声，就这个，就是第一个夹子上去的时候，食管中段的超声。食管中段的超声。
你前面你保存了吗？
你保存了吗？
前面没有保存吗？新民？
对，食管中段。
Because I think it's very important to have no regurg in the anteroceptor commissure after implantation of the first device. Otherwise, you have to move towards more to the commissure.
I totally agree. Also, if you examine the tricuspid regurgitation only in transgastric, then you might be misled.
This is from middle esophageal view. This is a view from middle esophageal.
This looks excellent to me.
Okay. So dramatically reduce it after the first clip was implanted. So now we are going to put the second one. 再回到上个网第二个上去的时候。
For those who are not so familiar with the dragonfly, can you just elaborate a little bit on the differences between the dragonfly and what we have in Europe, like Pascal, like
many differences. You know the whole I think the clip, there are big differences about the clip.
Yeah.
Actually, dragonfly has also a spacer, but the spacer can be compressible. So you can keep the arm angle. You can release the device while keeping the arm angle from 0 to 45 degrees. So this is quite unique. This is the first unique.
So that means the spacer...
The spacer is a compressible space.
Might have different sizes, you know, dependent on the amount of closing the clip, yeah?
Yes, you're right. If the patient regurgitation already gone, we may keep some angles. We don't want to tight too much, may damage the leaflets. So it's a flexible, but from 0 to 45. So we can, while keeping the angle from 0 to 45, we can release the clip. It's very unique. The other one is you can see that the handle is very, very useful. You know, when we use, could you zoom on this one? Zoom on this handle. I don't think you can see the handle. You know, when we do the tricuspid TEER, the biggest challenge is eliminating the hogging. Very hard to eliminate hogging. So we have a discussion with our engineers. We developed this one. We add one more handle on the big sheath. On the big sheath, can you see that? We have regularly, can you see that? The big sheath, middle sheath, and the CDS. But each sheath regularly, on each sheath, there are 2 handles. One controlling anterior, posterior, the other controlling the lateral and the medial. However, for tricuspid TEER device, we add one more septal lateral handle on the big sheath. So very easy for us to eliminate the hogging. You know, sometimes we without this one, very hard for some cases, very, very challenging to eliminate the hogging. But if we added this one, it's very easy.
And the clip is made of cobalt chromium, or?
Excuse me? Pardon?
The metal of the clip is cobalt chromium, or what is it?
Yeah, 合金。
Oh, I think my cobalt chromium. 金属是什么金属 ？Engineer, could you ask 什么金属
？Nitinol.
Nitinol.
It's nitinol.
I don't think so. I think the spacer is nitinol. The spacer is nitinol.
It would be a big difference if it's nitinol. Maybe you can clarify that meanwhile. And,
maybe
what is
maybe
the
I invite the
size?
engineer to answer the question.
And the size of the clip is you have different
话筒移
sizes.
到前面来啊。Could you come on here? I invite the engineer to answer this question. Or professional. 你说看，你声音。
Okay. What's the problem?
什么金属做的？这个 clip 是什么金属做的？
It's mixed. I think it's mixed. The nitinol and the nickel and the titanol. It's mixed.
液态是吧
Yeah.
Ti and nitinol cobalt.
Okay.
Right? Yes.
Okay. And the sizes are different.
Yes, we have four sizes. Shorter and narrow, wider and longer.
Yes.
So, 4
9.
times 9.
Yes.
4 times 9.
Okay.
6 times 9. 4 times 12.
Yes.
6 times 12.
Yes.
6 to 12.
Yes.
6 to 12.
I see.
4 to 9.
So
4 to 12.
similar
6
to
to
what we
9.
have,
6 to 12. Yes.
With the Pascal and the mitral clip. Okay, so maybe we go ahead with the next clip.
Yes. 继续啊，第二个。
So now we decide to put the second one just parallel to the first one, next to the first one. So that's our strategy. So now can you see that? Now we 把第二个进去的时候看，先看第二个，在那个这个看不清楚啊，是第一个还是第二个？
第二个，这是第二个。
你位底的呢？
你现在位底。
Yeah, this is the second one. Yes.
Here is a transgastric view. Can you see that? 你不要先夹拢啊，你这已经夹拢了。
没有
你看在第二个。
没有。
Can you see that? Can you see the two arms on the transgastric view?
Yes.
The orientation is almost the same as the previous one.
Yeah, now right we close.
Can you see that? Now we put the second one is already there.
切牢。
We have not tightened to the end.
切牢了吗？
we just tightened to the half.
切牢。
expand。
你要给他们判断怎么样判断那个半叶在上面，你有个 gastric view，不是那个
transgastric view，
或者两个平面打一个 transgastric view，然后 back to the esophageal view。
这里
So for the second clip, now we are live for the second clip. Is it right?
Yes.
Yes,
Okay.
still here.
Fine.
We have not released it.
We are ready, waiting
Can you
right
see
here.
that? Can you see the screen? Can you see fluoro? You cannot see fluoro.
张力怎么样？看隔半，
应该行。
张力还可以吗？
对。我到位底看一下吗？
We have not
你到位底看看啊。
released the second one yet.
Yeah, go to transgastric view.
Now we go to transgastric view.
Yeah, so the imaging quality of the middle esophageal view is quite poor. Yeah, so just a minute. 就是偏高一些。
So you are now checking for the leaflet insertion, is it correct? Or what you are doing right now?
Yes, we already checked the leaflet where inserted.
Yes.
So we already get the grip down. Now we tighten almost to the end.
You're
Dr. Liu
looking
is
for
still tightening.
good imaging, huh?
先到前半。
So can you see fluoro? Can you see the fluoro?
Yes, the fluor is clearly visible.
Fluoro, you can see that the two clips are quite parallel. You see that? Alignment is quite similar.
Yes. And you've turned
side
your
by side.
angulation of the fluoroscopy so to look from your implant in a straight way through, so you can make sure with fluoroscopy to place the second clip exactly in the same rotation. So this gives you a lot of control. This is a
Yes,
very good
yes.
technique.
Yes, I fully agree with
appreciate
your
it.
comment. For the second clip, actually, fluoro image is
然后
very
我都继续
important.
关了啊。这边切到后半，切到隔半，
好的，
隔半还可以对吧？也不用松，对不
我就
对？
不用说了。
好。So we close.
So now
the first
we,
one all the way.
when we tighten the clip, we need to figure out whether the tension. So sometimes we just move the CDS system a little bit forward to try to eliminate the tension.
Okay.
Can you see that?
Please check.
Almost gone.
Yes.
The regurgitation is almost gone.
Check the gradient.
Would you also show mid-esophageal or deep esophageal for the regurgitational jet? Because in this view, the regurgitational jet comes towards you as a spectator.
Could you go back to the chest esophageal view to see the regurgitation?
Yes.
We go back. Now they pull back the transducer to the esophageal, middle esophageal.
All of a sudden, there's something.
多了。Only mild.
You think we need one more clip for the patient?
What is the opinion of the panel? How shall we go ahead from here?
So what from my point of view, if I may, so we see a further reduction in tricuspid regurgitation. However, I would appreciate seeing the second plane using biplane or whatever with the regurgitational jet. And now you've also found a very nice window. If you could put on the color, we could see.
The color is on, please.
Yes, so in both planes, the regurgitational jet is further reduced. So I don't think that you would need a third device. And using the bicuspidalization technique also worked as well, although apparently a Clover technique was considered at least.
Yeah.
Yes, we don't need a Clover technique for this patient.
Yeah, I mean, I agree. I think you've achieved a really good result. It perhaps highlights that whilst there are these different techniques that are described, taking the simpler, better tested approach makes sense because you've proven that you didn't really need to complicate it, which was a consideration before the procedure. So I think you've done very well with the two devices. I wouldn't put a third one in here.
Okay, now they are releasing the clip. Could you focus on how they release the device now?
So with the Pascal, we typically see an improvement in TR after we release the clip, at least in some cases. What is your experience with the Dragonfly?
Pascal is not available in China until now, so I think the unique spacer design is very important. For some patients, we cannot tighten the leaflet too much. If tighten may damage the leaflet. So for many patients, we just keep some angle. So we just eliminate the regurgitation, but while the wire don't damage the valve. Also, the handle is very important. The handle is very, very good for quickly eliminating the hugging. Also, I think the handle system, is a very articulated. Each skill is very easy to manipulate. Color is on, please.
So we don't have Dragonfly in the United States. But we do have Triclip and Pascal, and they have different mechanisms for everting or getting back into the right atrium.
That's how I take.
What is the mechanism if you get tangled up in cords and you needed to get back and reset?
Yeah, we can reverse. Yeah, I think the technique is quite similar with the Triclip. Yeah, we can reverse.
We can reverse. We can independently grasp or simultaneous grasp, and but the mitral clip system is Chase does show the operator friendship. I think that this one is very operator friendship, very easy. We don't need to, like when we do the MTR, we don't need to, the straddle. Sometimes for the Dragonfly system, you don't need to, you don't need to have a forced straddle, but you can bet. You can bet. So welcome you to try this device. You can feel a lot difference.
And can I ask you, obviously, look at color. I could see you were checking the gradients. Do you look at any other echo parameters in terms of assessing your results, your RV forward stroke volume? Do you look at any, because we obviously know the limitations of any one parameter. So how do you assess your outcome on the table?
That's a good question. Very good question. Thank you for your excellent question. Hi, Dr. Lin. 我们术后是怎么评估的？除了这个柳根贴以外，你有什么指标来反映？比如它肺动脉压力或者它的右心功能啊等。你错些哪些指标？
一个是肝静脉，
你可以说，话筒转上，你给他评估一下啊。
一个是，
时间还有，对，你一个一个指标边评估边说。
肝静脉的逆流嘛，对吧？
对。
一个个程序来。Pressure grading 是。
Yeah, a little bit high.
You already?
Yeah, to 0.
So what do you think the RA pressure? Is it just a red atrium pressure?
Yes. 因为你用中文讲，我们用英文翻译。
这是肝静脉逆流，我们看一下到底有没有好转。
So now we check the inferior vena cava to see whether the flow is reversible or no reversible.
The hepatic vein reversal is usually not seen right away. You don't have that same immediate gratification like the pulmonary veins when you do mitral clip.
那个 mitral clip 不一样，对，马上就。
一个就是另外一个就是最大这一束的一个反流型的宽度到底有多少？
这是现在的
反流啊，
反流型的一个宽度。
不多了，已经完全可以接受了。
对。
And so we are going to see the.
That's a very good result. Congratulations.
The regurgitation, quantify the regurgitation quantity.
Yeah, so we don't need the third one, right? So we can finish the procedure, right?
Yeah, I think it's very well done and very instructive. So, and you ended with a really nice result. So thank you very much from Frankfurt, and applause to your.
Thank you all for your comments and the discussions. Thank you so much.